that would be beneficial for the audience to hear. So you will note from the original agenda that there are fewer abstracts to be presented, but as in previous years, we will be dividing the meeting into sections for newly diagnosed transplant-eligible, transplant-ineligible, relapsed refractory patients. And after each of those sections, I will provide sort of a brief reference point for discussion among the panelists from some questions. We also wanted to allow ample time at the end of everyone's presentation to receive questions and comments from the audience. And to do this, please submit your questions on the chat and direct them to our host, Ledia, L-E-D-I-A. And then the questions will be managed by our physician staff, and we'll try to get to as many as possible. So I will invite our first presenter, who is well-known, Dr. Arleigh McCurdy, who will kick off the section on management of transplant-eligible.
Thank you, Donna. And so I have the privilege of presenting a CMRG paper actually presented by Dr. Cote in one of the oral abstract sessions entitled Real World Results of Auto Stem Cell Transplant in Newly Diagnosed Patients, a multi-institutional report from our group. Next slide, please. There we go. So as many people are familiar, the Canadian standard for patients with newly diagnosed myeloma who are eligible for transplant is a Bortezomib-based induction, usually Cybord-D, followed by a high-dose melphalan and auto stem cell transplant, followed again by maintenance lenalidomide. And typically tandem transplants are reserved for high-risk patients. And this is done in some centers across Canada because the data is of course, controversial. So just as background, the CMRG is a large national network of researchers from 16 institutions. And our database now includes over 9,000 patients with the goal of being able to look at real-world outcomes, patterns of treatment, and identify gaps and areas for further research in myeloma and set benchmarks for patients. And so this study was really to look at the outcomes of patients who had a stem cell transplant as part of treatment for newly diagnosed myeloma over the last 15 years. Next slide, please. So we can see some of the key background or baseline characteristics on the left-hand side. So this analysis included just under 4,000 patients who had an auto stem cell transplant, and over 90% of those were single transplants. Most patients were ISS stage 2 disease, and about 20% high-risk patients, recognizing that we did not have a routine access to fish across the country in the early parts of these 15 years, so missing some patients. Some initial key outcomes are presented on the right-hand side, the PFS in the left column and the OS in the right column. And what we can see here is patients who had a single stem cell transplant had a PFS of 35 months and a median overall survival of 126 months. And that's all comers, so greater than 10 years, which is an excellent benchmark for these patients. When we look at our high-risk patients, we see that the tandem transplants had a prolonged PFS, but in fact, an inferior overall survival, and that is fodder for further research. In our standard risk patients, we see a PFS of 46 months and a median overall survival of almost 160 months as our benchmark, with the tandem transplant for standard risk not being yet met. Next slide, please. And some other data from this paper that it is a slightly different look. We are looking here at the impact of maintenance therapy. And the lower two curves, the blue and the purple, is the PFS curves, and the upper two curves, the red and the green, is the survival curves. And what we can see here is that all comers, the median PFS in the purple line was 48.8 months for those who had maintenance versus 24 for those who didn't. And the green overall survival curve shows a median OS of 159 months versus 105 for those who had maintenance and who didn't. Looking at the stratification at the bottom at standard risk versus high risk patients, we see here that there is an improvement in PFS when any maintenance was given, and that benefit was maintained in our overall survival groups with a PFS benefit of about 30 months in both standard and high risk patients who receive maintenance therapy. Next slide, please. So summarizing this for the Canadian context, this is a broad overview of a comprehensive look, I guess, of 15 years of experience of doing stem cell transplant in the real world setting, and encouragingly showing a median overall survival longer than 10 years in the vast majority of patients. And it highlights the contribution of continuous maintenance lenalidomide that our patients have had in Canada. It serves as a nice benchmark for us, and we have some further analyses going on to look at some smaller groups within this big cohort. And I'll pass it back to you, Donna.
Thank you very much. I think, again, these are our benchmarks, and the good news is we have some subgroups. 160 months is how many years? Is that 13 years median survival in a system that we often worry is inadequate. But the world has changed. And I think you'll sense over the next couple of presentations that we can't rest on these relative laurels or successes. And at CMRG and all of us in our individual practices are committed to moving to the next level, as you will. And you're about to hear the next level from Dr. Sebag.
Thank you, Donna. So as Donna said, yes, we risk being left behind. And this is a good example of us catching up with VRD in induction therapy, but being leapfrogged with the addition of Daratumumab. So in this poster presentation by Ajay Cherry, this is a long-term analysis of the Griffin study. So it's a study that aimed to compare the addition of Daratumumab to VRD induction. So in this trial, newly diagnosed transplant-eligible patients were stratified for disease stage and renal function, and then randomized to two groups. And the two groups were standard RVD induction, 21-day cycles, versus that same standard plus the addition of weekly Daratumumab IV, then switched to sub-Q. Patients were then transplanted, and then a consolidation consisting of the same 21-day cycles of either RVD or RVD plus weekly Daratumumab. And that was followed by 2-year maintenance of either lenalidomide alone at 10 for 2 cycles, followed by 15 milligrams for cycles beyond, or exactly the same dosage of lenalidomide with the addition of monthly or bi-monthly Daratumumab. The endpoints in this study were the rates of stringent complete response at the end of consolidation. And the secondary endpoints were the rates of MRT negativity by 10 to the minus 5 cutoff next generation sequencing, the overall response rate greater than VGPR, response rate, CR rate, PFS, and OS. If you can go to the next slide, please. So that's the background of the study and the study design. And already the study was published in terms of its primary endpoints, and that is post-consolidation SCR, and where it showed a clear improvement in the group that received Daratumumab, 42.4%. versus 32%. And that was a median follow-up of 13.5 months after the end of treatments. So it did meet its pre-specified significance endpoint. But this particular poster really looked at long-term follow-up, so greater than 1 year post-completion of study treatments. And it focused particularly on high-risk groups, such as those that are older than 65, and those with 1, 2, or more cytogenetic abnormalities. They define cytogenetic high-risk abnormalities as by FISH, deletion 17p, translocation of 414, 1416, 1420, or the amplification of 3 or more copies of 1q. And so the endpoints for this particular long-term study are the same as the overall study, that is the SCR rate, with secondary endpoints of MRD and other responses and progression-free survival. Next. Thank you. So the median follow-up, in fact, was 49.6 months, so quite long. And although the PFS was not reached, a point analysis of or point estimation of the PFS gave the advantage to DRVD with a hazard ratio of 0.45 overall. Again, in this subgroup analysis, looking at MRD negativity by next-gen sequencing, the MRD negativity rates were much higher for DVRD versus RVD in virtually all patient subgroups, including patients with ultra-high risk, that is 2 or more high-risk cytogenetic abnormalities, and those who did not achieve deep responses to therapy, i.e. patients who had a best response of less than VGPR after induction, or were MRD positive after the consolidation. So all of these patients, or these subgroups rather, benefited from DRVD with respects to MRD negativity. So does that translate into a better PFS? Next slide. So largely, yes, but again, keep in mind that medians have not been reached. And so these are point estimates. And largely, most of the subgroups did favor RVD versus RVD, except for the patients who had 2 or more high-risk cytogenetic abnormalities, or those who, after 2 years of maintenance, either failed to achieve a VGPR or were still MRD positive. So in the exploratory analyses, so not the primaries, the patients who received DRVD had improved PFS compared with those who received RVD, regardless of whether they achieved VGPR after induction. So this is after induction. Patients who received DRVD had improved PFS compared to those who received RVD, regardless of MRD status after consolidation. And patients with 0 or 1 high-risk abnormalities who received DRVD had improved PFS with those corresponding RVD high-risk cytogenetic abnormality groups. It was noted that patients with a 1q amplification did better with DVRD than RVD. And again, to repeat that PFS was not improved for patients with receiving DVRD versus RVD for patients with 2 or more high-risk cytogenetic abnormalities, but this sample is quite small. Next slide. So in conclusion, DARA in induction, consolidation, and maintenance produces a higher MRD negativity rate for all subgroups. This translated to an improved early PFS analysis, which favored DARA in all these subgroups, except for patients with 2 or more high-risk cytogenetic abnormalities, or who remained after 2 years of maintenance MRD positive or had a less than VGPR response. So how is this applicable to our Canadian clinical practice? Well, at the moment, none of us can get Daratumumab in induction or in consolidation or maintenance. I note that in this particular trial, the Daratumumab was continued at 2 years. Lenalidomide was allowed to be continued beyond that if it was institutional policy. And if we were to have access to Daratumumab for these type of patients and they were to progress beyond that 2-year mark, we would like to ensure that we'd have access to retreatment with the anti-CD38 antibody. And I'm done.
Yes, thank you very much. I think this has established a new benchmark, and I think in our short discussion section later on, I have an older but a representative PFS curve. I think there's some questions about how many patients continued on off study. And I think there are questions that will be brought up by the next discussion, because Canadian results have depended so highly in the absence of RVD up front or immunotherapy up front on maintenance. So are we poised with better induction or consolidation to abandon that approach? And I think these are important questions that will be answered in time, but in the short term, we want to select the best approach for our patients. And to talk about different monitoring strategies, I think our next speaker is Dr. Chris Venner, who's going to talk about MRD and mass spectrometry as we try to assess the depths of response and predictive factors for outcomes as we start to think about adapting treatment based on these parameters. So, Chris?
Yeah, thanks, Donna. So I thought this was actually quite an interesting abstract. So it is yet another look at the GEM 2014 maintenance trial, but not only looking at the MRD status of patients, but adding yet another layer to the MRD question, which is a more convenient method potentially of at least screening patients that might be MRD negative in the marrow using mass spectrometry. So if you go to the next slide. So, you know, as a bit of background, I think questions still remain about the utility and feasibility of response-adapted therapy, although I think it is compelling enough that, you know, certainly there's lots of clinical trials on the go with this idea in mind. If it is deemed clinically useful, a big question will be how to introduce a response-adapted therapy in a way that is truly viable and clinically applicable. And the main sort of strategy that we have to guide our treatment at the moment, although not widely available in Canada, is marrow-based minimal residual disease assessments. And this can be done either using next-generation flow cytometry or more of a genomic and sequencing-based approach as per the adaptive assay. And both of these have been established as current standards of care as per IMWG criteria. Of course, it is a marrow-based assessment, and having a non-marrow-based assessment to guide treatment and to select those that might benefit from and require the more invasive testing and thus more expensive testing, it would be nice, and mass spectrometry may be a tool that we can use to look at that. So this study actually looked at incorporating both of these endpoints in a MRD-directed type treatment strategy. And we now have some long-term follow-up to assess the impact of it. So if you go to the next slide. So the study schema here is summarized on the left. This is actually a combination of two trials. First is the GEM 2012 MENOS65 trial, which looked at RVD times 6 cycles, and then the randomization in this study actually was MEL200 versus BUMEL, which is a combination that we've also tested here in Canada. All patients then went on to have RVD consolidation for an additional 2 cycles, so in total 8 cycles of RVD. There was an extension of the study, the GEM 14 main study, or the maintenance component of the study, which randomized patients yet a second time to receive either Len-Dex as the one maintenance arm, or more potent triplet, what was thought to be a more potent triplet maintenance strategy with Dexamethasone, Lenalidomide, and Dexamethasone, given over the schedules described here. The MRD assessments were done at 0, 1, 2, 3, and 4 years, and the MRD-directed intervention was determined and performed at the 2-year mark, and that's summarized on the right-hand side of things here in the study design. So just so everybody is aware, the MRD was assessed in this study by next-generation flow cytometry. Sensitivity was down to 3 × 10⁻⁶, so not below 1 × 10⁻⁶, which I think now has been established as a more up-to-date standard of care, although better than 1 × 10⁻⁵. If a patient was MRD negative, maintenance was discontinued at the 2-year mark. So all of this assessment was done and intervention was done at the 2-year mark. If MRD remained detectable, then patients actually continued on whatever maintenance arm they were assigned to for an additional 3 years for a total of 5 years of maintenance. But again, important to recognize that all patients eventually stopped maintenance therapy in the study. At each of those MRD, bone marrow-based MRD assessments, mass spectrometry was also done in the serum, which is what we have available for us to analyze here today. You can go to the next slide there. So what was presented at the ASH meeting was all of those patients that achieved that 2-year endpoint. So it is somewhat selected already for patients that were already destined to at least live and be disease-free at the 2-year mark, which does explain some of the excellent outcomes that we see here. So within this category of patients that achieved that 2-year mark, the MRD negativity rate was actually quite impressive at 71%. The mass spectrometry negativity rate was also quite impressive at 73%, very similar. And then interestingly, the immunofixation negativity rate, which would be, as we standardly do here in Canada, was very high at almost 90%. To break this down a little bit further, there were some interesting features here. So of the patients that were next generation flow negative, so bone marrow assessed negative, they did go on to, but were also mass spec positive. They were able to characterize what those relapses were all about. And in fact, 6 of the 8 relapses that fit that pattern actually had extramedullary disease. So would not have been expected to find any MRD in the marrow, but clearly still had systemic relapse outside the marrow. And then for those patients that actually had mass spec negative disease in the peripheral blood, but positive disease in the bone marrow, those patients, or 10 of those 16 patients, actually had light chain only disease. And in this particular mass spec assessment, they did not include patients that had light chain only disease. That data is forthcoming. It is possible to do it with the assay they used, but was not presented. So in fact, the vast majority of patients that are MRD negative by the bone marrow would have been MRD negative by immunofixation, thus potentially implying that the immunofixation could be used as a cheaper screening method to figure out who you would actually want to do the slightly more sensitive testing. If you go to the next slide. Now, to put those depth of response endpoints into sort of a more survival type sort of connection, we have the Kaplan-Meier curves here, sort of demonstrating the patients that or what the outcomes for patients that achieve next generation flow MRD negativity. So on the left-hand side there, the ones that were MRD negative had really quite a remarkable MRD disease-free survival. The median PFS still over 80%, now approaching 5 years, which is quite impressive. For those that did not achieve MRD negativity, the median PFS was only 3 or less than 3.5 years, which is interesting, given that most of those patients would have relapsed prior to the planned 5 years of maintenance anyway. So they were destined and were predicted to respond or to relapse well before their planned maintenance course would finish. Similarly, we see the same distinction between mass spec MRD negativity and positivity, and obviously favoring the MRD or mass spec negative patients. The curves are a little bit closer together and likely accounted for by those few patients that were not picked up as MRD negative by mass spec, but by next generation flow, but were negative by mass spec. And then the last important feature is the immunofixation really is no longer relevant for these patients as a prognostic factor. And that's likely because there's very few patients in the end that are not in CR. So because of the more potent regimens that we have available, we actually do need these more sensitive tools to differentiate our patients and really utilize that as our endpoint for any response adaptive trial. If you go to the next slide. So as far as the applicability to the Canadian landscape, I think this is yet another trial that lends support certainly to the introduction of sustained MRD negativity as a very important prognostic factor for frontline therapy. And I think it also lends support for the idea that mass spectrometry done as a non-invasive screen in the serum and relatively cost-effective screening tool can be used to find those patients in whom the MRD assessment on the marrow is justified. I think this type of an approach, especially incorporating the mass spec, could be a model for response adaptive therapy, whereby the MRD is tested about the 24-month mark. I think that's probably where we will go, although there are trials that do this at the 12-month mark. And you could look at a scenario where mass spec is done first, and then the MRD by the Marrow criteria is done only if the mass spec is negative, and then potentially stopping maintenance therapy based on the trials that we have. It would be great to have more long-term data to ensure that we really haven't taken away from a potential response and success for patients in whom we stop therapy, but I think we finally have the tools in our toolkit to do this. It also demonstrates the relatively poor outcomes for patients that are MRD positive, be that by mass spectrometry or in the marrow. And for these patients, we actually don't expect them to hit even those benchmarks that we have in our minds presently for our current Canadian standards for the median PFS. It's well less than 5 years. And I think this also lends credence to the concept of intensification of therapy for those that do not hit this endpoint, although the exact methodology for intensification, et cetera, does need to be tested in a formal prospective study. And lastly, just from a cost effectiveness standpoint, if we actually could come up with a strategy in this way, I think it is important to recognize that, in fact, the majority of patients using the more potent modern therapies will actually achieve MRD negativity in a sustained fashion, and stopping treatment could actually lead to quite considerable cost savings and improve quality of life in the long run for patients. So with that, I'll turn it back over to you, Donna. Thank you.
Yeah, thank you. Next slide, please. So to try to kick off the discussion, I think the obvious point is, while our own results have been quite strong, the Griffin study, and as an aside, I don't know why it's named the Griffin study, really shows an amazing progression-free survival, and these curves now are maintained very high out to 4 years. So what are we doing to try to raise the bar for our patients? We only have one trial that adds a CD38 antibody to induction and maintenance with the transplant, and that's the CMRG 008 trial that a number of centers are doing, and it adds the other monoclonal antibody besides Daratumumab, which is Tocilizumab, to our older platform, and it does continue Lenalidomide until progression, and we will be doing MRD as a secondary measurement at several time points. The other trials really at the bottom are all directed at post-transplant measures. And this is the last bullet, and they all have very similar design into after patients have had their induction and transplant by the institution's normal approach. If they're MRD positive at day 100, they're randomized either to lenalidomide alone, which is standard as you've heard, or an alternative. And the Auriga study is ongoing at several centers where the test arm gets Daratumumab and lenalidomide. In the Magnetism 07 trial, patients are randomized to lenalidomide or the BiTE, the bispecific T-cell engager, and Renalimab. An upcoming trial is patients can be randomized to lenalidomide or CAR-T, as per the KarMMa-8 study. And then there's a study in which the European Myeloma Network and CMRG are collaborators, which is called the EMN30 TEC4 trial, which has 3 arms: lenalidomide versus another bispecific, Tocilizumab, or the combination of both Tocilizumab and lenalidomide. There is a trial that is another EMN CMRG collaboration, the CARTITUDE-6 trial, in which patients in both arms will receive Dara RVD, and the randomization is either to stem cell transplant or the other CAR T cell platform that's most advanced in myeloma, cilta-cel CAR T. So you can see that these trials move far beyond just the CD38 antibody, and for a variety of reasons are built on post-transplant measures. Next slide, please. The other issue that's of great importance is the use of MRD to guide therapy. And right now, the only MRD assay available in a, I hesitate to say commercial, but a standard lab in Canada is the technique by flow cytometry, EuroFlow. That is a standard, well-described technique that detects 1 to 10 to the minus 5th cells that's available at University Health Network. However, it's not provincially covered. It can be requested. There's plenty of availability to run the test if there are funds to cover the cost. And so we can use this platform for our clinical trials, if the trial will pay for it, and physicians at Princess Margaret or other centers, if they can get funding from their center or I guess pay the cost themselves, can order it. But I think it is interesting, and I think Chris introduced this, it may be beyond MRD at 10 to the minus 5th. Mass spectrometry of the marker protein in the urine has an advantage because myeloma is spotty. Accessing one site in the bone marrow may miss other marrow sites or extramedullary disease. And we didn't have time in this session to talk about all sorts of potentially more accessible techniques than marrow MRD that were presented at this meeting, such as even recovery of normal serum immunoglobulin levels being a very positive prognostic sign for outcome. Circulating normal plasma cells when patients are getting bites or CAR T cells may mean that the effect is wearing off. I mean, we think of normal plasma cells as good, but it means the target isn't being hit up because bispecific CAR T cell platforms can't tell normal from malignant plasma cells. And then, of course, PET CT scan can give a nice overview of extramedullary disease. Now, it's going to be a long time before these approaches are funded in Canada, but there are several industry initiatives underway to help us get these assessments into Canada. And we at CMRG are integrating MRD assays into as many trials as we can. Otherwise, I think our results will just not be relevant in the current age. So we can start a bit of a panel discussion now, and I think you may hear different opinions. And I'll start by asking the speakers, do you feel with what we have available, 10 to the minus 5th, even if sustained, is a sufficient marker to discontinue therapy after stem cell transplant? Anyone want to take that on?
I'm happy to start, Donna. I would say no. I'll just drop the gauntlet. We have the ability to go down to 10 to the minus 6, and then there was an abstract that was presented at ASH this year that there is the possibility with CD138 selection, you go down to even 10 to the minus 7. Well, how feasible that is on a routine basis remains to be seen. But 10 to the minus 6, I think, is more predictive. And if I had an interesting meeting with the Adaptive folks just to see what their standard of care printout shows up like if you order this test. And their assay goes down to 10 to the minus 6. So if you have somebody at 10 to the minus 5, it will show up as positive. So in your heart of hearts, you know you can detect disease. And if I know that there's disease present, I will be less comfortable stopping therapy. So I would say that because we have the ability to do it, I think you'd have to go below our limit of detection before I'd be comfortable stopping.
So Darrell, what are your thoughts?
Thanks, Donna. I agree with Chris's comments. I think it's a good question for trials still at this point. I think the question's unresolved. I think for now, I personally feel that patients should remain on maintenance therapy until we have a clear answer.
I agree as well with Darrell and Chris that I don't think there are enough prospective trials for me to feel comfortable under treating a significant portion of patients. And that's my fear, is that we'll be under treating patients that are, that may fall by the wayside because of technical issues, either the sensitivity or even, performing the assay itself. I have a problem with just randomly biopsying a patient and expecting that result to be uniform. And I guess that's where the mass spectroscopy comes in. But that's, in my mind, very far from prime time. The results presented by Dr. Venner are very, very interesting. The correlation is interesting. It doesn't sound like it's there yet. But I think with further refinement, it may get there.
Yeah, I have a couple of thoughts. One is, I think it has to do what the goal of using it is. If it's to just define a deep remission where you can probably stop treatment for a while, you get a deeper response, probably takes longer to grow back. But if your goal is to improve the PFS beyond 4, 5, 6, 7 years, that's going to, in my mind, require a more comprehensive look at the disease. We didn't talk about one abstract that stopped therapy, only if PET CT was negative in addition to sustained MRD or mass spec or all of these. And the other big question in my mind about undertreating these people is we don't yet, and we will, have an idea of what is the treatment burden when the disease reappears if we stop it. We've seen some patients are just MRD positive, but some go directly to symptomatic disease. And it seems unlikely that just going back on oral maintenance is going to fix it. You're going to have to go on more intensive therapy. And then when you stretch this out over the years, what does that mean for the patient? An oral pill and maybe some IV every month or two versus going back on intensive therapy. So I think we hopefully will hear these questions, but I think we don't want to undertreat people, although there are clearly people that do well for prolonged periods off treatment. So I'll throw it open. Arleigh, Julie, do you have comments about this?
Go ahead, Arleigh.
I was going to say I don't have anything significant to add. I agree with everybody. It's exciting. It's promising. It is not, in my opinion, ready for prime time uptake.
Yeah, I concur.
One thing I would add is that one of the reasons I don't think it's quite ready for prime time in Canada right now is that actually the vast minority of our patients will even qualify. Because in fact, we know this from the CMRG 001 study that the percentage of patients with standard Canadian therapy, Cybo-D, transplant, and maintenance, they get to MRD negativity by MRD negative CRs by 10 to the minus 4 MRD is less than 20%. So right now, we don't have any regimens available that will actually even provide that opportunity to stop therapy. But I think introducing MRD testing capabilities into the Canadian landscape now, under the assumption that we will get quadruplets or more potent transplant-based regimens in the future, sets us up so that 2, 3, 4 years from now, we will have the capabilities to find those patients and hopefully keep up with the times for as that data evolves.
I think one important message too for our listeners, particularly other physicians, is MRD requires thought when you do your marrows. You have to have a good marrow to get the next generation sequencing. And if you don't get a first pull with a good volume for flow, you may get a result, but the sensitivity depends on the number of cells. And that was a problem with MCRN-001. We thought we were going to get 10 to the minus 5th. That was what the technique said. But what happened when we kind of did our routine marrows, we didn't get enough cells, and that's why the sensitivity was 10 to the minus 4th. So for those of you that do marrows, we really are going to have to focus on first pulls, lots of cells. And for these MRD studies, you know, we think using a clot sample in samples that are not routinely being stored in path labs will be needed for the initial development of what's going to be looked at through next generation sequencing. So you're going to hear more about that, because if we don't have that initial sample at diagnosis that defines the characteristics of the next generation sequencing, these patients won't be able to go on trials. And we're working on educating the community, because this is our main way of getting immunotherapy into our first line transplant patients. So we are definitely behind schedule. So it's good we cut some abstracts. So we'll move on to newly diagnosed transplant-ineligible patients. And our next speaker is Julie Stakiw, who's going to provide us an update on the landmark MAIA study as presented at ASH.
Thanks, Donna. So I like to consider the MAIA trial the gift that keeps on giving, and every meeting there seems to be another subgroup analysis, and this meeting they think that there were 3 posters presented. This particular one was a poster by Dr. Thierry Falcon that looked at MAIA based on age subgroups. So next slide, please. Just again, so that we're all on the same page, the MAIA trial was in newly diagnosed transplant-ineligible patients who were randomized 1-to-1 to receive Daratumumab, Lenalidomide, or Dexamethasone versus our standard at that point, which was Lenalidomide and Dexamethasone until disease progression or unacceptable toxicity. I think we know the schema, and again, it was until progression. And we all got really excited in the primary analysis of the MAIA study with a follow-up of 28 months, where we definitely saw an improved progression-free survival in the DRD triplet combination versus the lenalidomide and dexamethasone doublet in transplant-ineligible patients. The follow-up now presented at this meeting is 64.5 months, and it was presented in a poster where the overall progression-free survival was 61.9 months in the triplet combination versus 34.4 months in the doublet combination. And in this particular poster, we're going to look at subgroups of patients who are less than 70 years of age, 70 to 75 years of age, and then the all-comers in the less than 75 age group. A separate poster looked at those who are older than the age of 75. Next slide, please. Again, this follow-up was 64.5 months. And what you can see here is that the median progression-free survival for the DRD patient populations and those who are less than 70 has not yet been reached versus the RD arm, which you can see really down in the green line there, which was 39.2 months. There is also the population of 70 to 75 analyzed on the left-hand curve in terms of progression-free survival. But what it's really showing is the biggest benefit for progression-free survival was in those who are less than 70. You can see the top curve in the blue versus the bottom curve in the green. On the right-hand side is the progression-free survival of all those who are less than 75 for DRD. And you can see there the median has not been reached versus 37.5 months. The bottom figure looks at the overall survival data at the 60-month analysis. Again, the median progression-free survival not yet been reached. But you can see again with the blue curves being DRD and the green curves being RD, again, the best benefit in overall survival, according to the hazard ratio, certainly looks to be between those who are less than 70 versus the doublet of RD. And on the right-hand side, the overall survival does show the 60-month overall survival for those all patients who are less than 75 for the triplet combination versus the doublet. Next slide, please. So the conclusion presented by Dr. Falcon indicated that the DRD triplet certainly demonstrated a clinically meaningful benefit versus lenalidomide and dexamethasone in the clinically relevant endpoints, including progression-free and overall survival, which I did show you. I didn't show you the overall response rate or the MRD negativity rate, as that's been presented well in other subgroups. But particularly from a PFS and overall survival across the subgroups of ages that I talked about, the most pronounced progression-free survival and overall survival benefit was seen in those patients who were less than 70 years. DRD induced deeper rates of responses across all of the subgroups evaluated. And as I mentioned earlier in another poster for the intention to treat population with a median follow-up of 64.5 months, progression-free survival for the triplet combination was 61.9 months versus 34.4 months. So the takeaway really here is that, again, with previously presented data, along with another poster presented in those who are older than the age of 75, there continues to be support for the frontline use of the triplet combination in the age subgroups presented for those newly diagnosed transplant-ineligible patients. Next slide, please. So in Canada, I think we know that DRD is now the standard of care in transplant-ineligible patients in frontline therapy, reinforces the benefit versus RD in all age subgroups. And I think, while we don't want to do cross-trial comparison, as Donna always said, we're going to go there and do that when we look at particularly that less than 70 age population and whether or not DRD is more appropriate in patients as opposed to transplant in that 65 to 70-year-old. And I'm looking to see what my panelists say about that one. And I'm done.
Thank you. Next slide, please. So as usual, I'd like to kick off this panel discussion by going back to our CMRG presentation that was at the International Myeloma Workshop this summer. And again, we've shown the benchmarks of our transplant-ineligible population over a 15-year period. And several points from this, we established that VMP and CyBOR-D are the same, with a median of about 2 years, and these are almost all weekly patients. So CADITH has looked at this, and I think we've made our point on the interchangeability of these regimens. And then, of course, the next step was getting lenalidomide Dex into those patients, which has shown the PFS has gone from just under 2 years to just under 3 years. Now, about 3 years ago, we did get funding for RVD, or lenalidomide Bortezomib Dex, and we can see that although the numbers that are out many months is still relatively small, you get the impression that we've made a dent in improving the outcome in these patients. But now we finally have Dara-RD. But I think there's still room for improvement in these patients. The studies that we've had in Canada include actually a CAR T-cell trial in this population. Several centers have done this, which randomizes transplant-ineligible patients to RVD versus RVD followed by CARTITUDE, the cilta-cel CAR T. We do have an upcoming study that looks at we hope, improved regimen from RVD, in which lenalidomide is replaced by a new class of drugs called the CELMoD. It's a new and improved IMiD with weekly Bortezomib and Dex, sort of IBD light. And isatuximab will be added based on response. And the reason is, even though we're very excited about daratumumab or isatuximab first line in these patients, if you can get by with 3 drugs, that's probably a good thing. And the CD38 antibodies are wonderful, but they do carry an increased risk of infection, particularly pneumonia. But there are strong needs for adopting treatments that are specifically relevant for our older patients that are frail, very advanced stage, or have other comorbidities. And to that end, the CCTG national group is proposed a study using the funded DARA-RD with treatment de-escalation based on MRD status. This trial is awaiting funding, but it is to see about dialing back to improve quality of life, etc. So I think the $1 million question in Canada that I'll pose to all the speakers is, with the amazing results from Maya and the very promising results in that group of patients in whom we work very hard to offer transplants to, we don't cut off at 65 or even 70. We've been transplanting fit people up to 72, 73. Do the Maya results change your preference for patients, or are they changing your practice patterns to offer Maya rather than a transplant in these, I will say, sort of borderline older populations? Maybe I'll start with Michael.
Sure. I mean, I love the Maya trial, obviously, and the results are really, really impressive. And certainly for older patients that are not really borderline for transplant, beyond the borderline for transplant, it's a no-brainer, as we say. Now, for that population that's sort of borderline for transplant, would I choose one over the other? The only, I mean, not the only, but one of the considerations to take into account is, what will you do after patients are refractory to lenalidomide and daratumumab? And in this population, when they're older and this is a functional cure, in the sense that this may be the only therapy they'll ever require, it's not a problem. But in the borderline younger, so let's say 72, 71, and you're 70 years old even, and you're given a choice between these two, I'm not sure. I may opt for transplant still and save the daratumumab for later.
Any other comments?
I would just add, I agree with Michael. I think it is compelling data, and it is important to discuss the pros and cons of both approaches to patients and the unknowns. I think it would be much more appealing to continue transplanting patients if we had an anti-CD38 monoclonal antibody as part of induction, because I actually think combining the two would probably give the best results. And so if we were able to use an anti-CD38 induction, I would feel more strongly about continuing transplant in most patients. So to me, I think we need to advocate for quads for induction.
I would agree with you, Arleigh. I think presently it's giving me pause. If I had a 68-year-old patient, I would probably err actually on the side of DRD, even if they were transplant eligible, because it's hard to argue with what will ultimately be, it looks like from the curves, over 70 months. So I actually can't in good conscience say that the transplant is going to give you better disease control. I can actually tell you in good conscience it probably won't, based on our numbers, and also based on even the benchmarks with RBD-based transplant-like determination with maintenance of progression. But I think that the pendulum will shift rapidly back once Griffin has longer-term follow-up out to 10 years and Perseus, et cetera, readout. And we have an anti-CD38 that we can work into the mix. I think things will shift back, and we probably will still be transplanting patients until which time we get CAR-T. And then that may change the game again. For what you do afterwards, that remains a challenge, and I guess we'll have that will be part of the next abstract that we'll present. Unfortunately, I think anyway we cut it. Even if you reserve your daratumumab containing regimen to second line, the outcomes after that are going to be quite curtailed. So you would just want to get as much as you possibly can in that first 1 or 2 lines of therapy.
Just the last comment before we go on to this. Hence, having all these trials, no, they're not a quad up front, except our CMRG trial. They're all post-transplant, but the hope is that that will help until we get a quad. I don't know if the panel feels that is a feature or a factor to keep doing transplants. But anyway, we're short on time, but I think this is one of the highest priority efforts, is to up the ante for our transplant patients. So if there are no comments, we'll move on to Chris's talk, which sets the benchmark for another high priority group of unmet need, which is advanced disease.
Yeah, so as was already alluded to by Michael, a challenge, it's a good problem to have, but a challenge we have now is what do we do and what are our expected outcomes for patients that have seen an anti-CD38 monoclonal antibody. We've presented some iterations of this type of data before, but this is a broader swath of patients that included Cetuximab exposed patients, and then also looked at triple class exposed versus refractory status. And again, this is from our big CMRG database. So we go to the next slide. So this was all put together by Dr. Visram, and really a nice overview of where we are at in Canada with the available therapies that are funded and at our fingertips. Again, the main outcomes we looked at were PFS and OS, specifically in those patients that had a prior anti-CD38 exposure. And I'll just jump right to the data in the interest of time. If you go to the next slide. So the survival curves and the patient characteristics are presented here. I think this is very much a very reflective population of what we see in our clinics today, where the vast majority of anti-CD38 exposed patients have already seen lenalidomide and Bortezomib. So the vast majority of our patients at this point in their disease journey are triple class at least exposed. And actually, probably the majority of those folks are triple class refractory. That determination actually depends a little bit on where you live, given that some provinces still don't use Bortezomib until progression. There may be a smattering of patients that are still PI sensitive potentially, but most patients will be IMiD refractory and certainly anti-CD38 refractory. And knowing this, looking at the benchmarks for both overall survival and progression-free survival, they're listed in the Kaplan-Meier curve on the right. So for triple class refractory patients, unfortunately, the outcomes are pretty poor. For median PFS of only 4.4 months, you may gain a little bit, likely driven by the proteasome inhibitor sensitivity if you're not outright triple class refractory, but the median PFS is still short at only 6 months. And these patients only live on average about a year to a year and a half after that determination of triple class, either exposed or refractory. As per the top two curves here. So if you go to the next slide. So I think, long story short, this remains a very important population for us to understand. And we have to fully recognize that we don't have great tools to treat these patients with the available therapies we can pull off the shelf. And we really do need a better strategy to manage these folks. I think we also need to ensure we have a good understanding of what the disease looks like at this stage of the game, because we know things like IMiDs and the anti-CD38 monoclonal antibodies do change both the disease as well as the immune microenvironment, which will have connotations for what we hope will help solve the problem, like the complex immunotherapy approaches. But these may also be a bit more challenging to give in these settings, given the necessity of a relatively functional immune system for them. So with that, I'll stop there, just again to try and make up a bit of time, but important benchmarking for us.
So thank you. So I think our results are virtually identical to results from the US in advanced disease, and set the stage for, I think, a more optimistic future from what the tools we had. And we have three presentations that look at, two presentations that look at new modalities, beginning with the bispecifics, which I think are a bit more low-hanging fruit for our Canadian centers and are also very promising. So, Darrell, can you update us on the Mezigdomide, or nicknamed Mezi?
Oh, I think the Cevostomab paper
Oh,
is.
I'm sorry. Yeah, okay. Yeah. Thank you. I looked at the wrong one. So the Cevostomab, one of the bispecific antibodies that many of us have had experience with, even for the last few years. Thank you, Arleigh. Next year, you can be the moderator.
Oh, no, you're doing a great job. No, thanks. I'm good. Thanks, Donna. So this is a study that many centers have been involved in looking at one of the many bispecific antibodies currently under study for relapsed myeloma, Cevostomab. In particular, this abstract looked at pre-treatment with Tocilizumab and was presented by Dr. Trudell. Next slide, please. So we know that Tocilizumab, an anti-IL-6 agent, has really been instrumental in managing cytokine release syndrome for patients being treated with bispecifics or CAR T cells. And there's some data that shows inhibiting IL-6 prior to treatment may abrogate the development of CRS and potentially the intensity of CRS without impacting the anti-tumor effect of the new bispecific. And so in addition to the ongoing Cevostomab phase 1 study, an arm was added with pre-treatment with Tocilizumab, with looking at whether a single dose prior to Cevostomab administration could reduce the risk of CRS. Next slide, please. So a single dose of Toci was given a couple of hours before the Cevostomab. Patients in both arms had standard pre-treatment with steroids, antihistamines, and Tylenol. And there was about 30 patients who received Cevostomab in this, or excuse me, Tocilizumab in this heavily pre-treated population. Next slide, please. And so the results are quite compelling, actually. On the left-hand side, you'll see the group who was pre-treated with Tocilizumab, or excuse me, who was not pre-treated with Tocilizumab, showing that while most patients still had grade 1 or grade 2 CRS, 91% of patients did have a cytokine release syndrome event. On the right-hand side, you see the patients who had pre-treatment with Toci and a dramatic reduction in CRS. Still predominantly grade 1 and grade 2, but 35% of patients experiencing CRS, which is quite an impressive improvement. Next slide, please. And so this, for us, really for the first time shows that prophylactic or pre-treatment with Tocilizumab reduced the rates of CRS that we're seeing and possibly the intensity. This is very appealing for Canada and beyond because administration of these agents requires hospital resources, hospital beds, and potentially inpatient time. And so reducing the risk of CRS and inpatient monitoring really has some important considerations for our ability to use these agents widespread, let alone the positive effects of patients and caregivers with dealing with CRS, which can be quite difficult on patients. And I'll stop there.
Thank you so much. I mean, we were all very excited with these results because right now, Tocilizumab, because we don't have the ability to admit patients on and off to go do the step-up dosing for bites, it's up to a 9-day hospitalization for Tocilizumab and up to 5 days for Lenalidomide. And in our very tight bed situation, we want a safe way to do this. So the next speaker will be Dr. Darrell White, who now will talk about Mezi, a cell mod for advanced refractory myeloma.
Thanks, Donna. This study also builds on the problem that Dr. Venner had presented a few minutes ago, which is essentially how to treat patients who have had essentially all of the agents that we had access to as of a few years ago, at least. And this is, again, one of these off-the-shelf agents that appears to be quite promising. So Mezigdomide, which is a cell mod or a cereblon E3 ligase modulator, in this case combined with Dexamethasone in heavily pretreated patients. And these are preliminary results of a trial looking at that combination presented by Paul Richardson. And I should say that the trial is being run at many Canadian sites currently, including a couple of Canadian authors on this paper. Next slide, please. So this is quite straightforward. The background, I think, has already been alluded to. Essentially, Mezigdomide is essentially an enhanced IMiD, so drug-like Revlimid and pomalidomide, only more potent in terms of inducing apoptosis of the myeloma cells. It does demonstrate potent synergy with other myeloma agents, anti-myeloma agents, preclinically, and will be tested and is currently being tested actually with many of those. So this particular study is an ongoing phase 1/2 trial looking at the mezigdomide alone or in combination with dexamethasone, and then the patients presented here received both. The results of the dose expansion trial are presented here and presumably will go on to further study. So the dose that's going forward for further study of the mezigdomide is 1 milligram daily in a 21 of 28 day schedule. So familiar to people that have been treated or have treated patients with lenalidomide or pomalidomide. And the patient population themselves, the patients had at least 3 prior lines of therapy and were progressing on their last line of therapy and had to be refractory to lenalidomide, pomalidomide, a proteasome inhibitor, and an anti-CD38 monoclonal antibody. So by definition, triple class refractory. And they're looking at response rates and as well other measures of safety and tolerability as well as efficacy. Next slide. So the data presented were updated quite recently. So 101 patients enrolled had received mezi plus dexamethasone at the dose going forward for phase 2 study. Patients received either 40 milligrams of dexamethasone weekly or 20 depending on age. Median age of the patients was 67, and you can see there were patients up to age 85 treated. Median time since diagnosis just over 7 years, and of note, plasmacytomas were noted in a relatively high percent of patients at about 38%. The cytogenetics is a little hard to interpret, as many patients did not have the study done, or at least were not evaluable. Prior regimens was median was 6, with a range up to 15. And all patients were refractory to the last line and triple class refractory, as I noted, as well. About 40% were pentadrug refractory. Next slide. So the results of this trial. So follow-up's relatively short at just under 6 months. Median number of cycles received was 4. A minority of patients continue on treatment currently, and the main reason for discontinuation was progressive disease, which is important because it wasn't toxicity of the regimen. Response rate overall was about 39.6%. Some of those were high-grade responses. Majority were partial remission or very good partial remission. Median progression-free survival, 4.6 months. And when you start looking at the subgroups of patients, so of those patients with plasmacytoma, the response rate was respectable, about 30%. And in those patients who had prior anti-BCMA therapy, about 50%. The toxicity, important to look at here. So the majority of patients had grade 3 or 4 treatment emergent toxicity, and most of that was hematologic. So a lot of neutropenia at about 74%, but fairly, acceptable rate, I think, of febrile neutropenia at about 15%. The thrombocytopenia occurred in about 3/4 of patients at this level, and infections were observed in about 1/3 of patients. Other grade 3/4 toxicity was uncommon, which is an important point as well. So overall, the combination had manageable safety profile, has promising efficacy. Further studies are ongoing, and the further studies I think of interest will be mezi with different combinations of anti-myeloma drugs. Next slide. So applicability to our practices, I think mezi combined with various partners is under study at many centers worldwide, but including multiple Canadian centers. The placement in trials appears to be taking the traditional place of pomalidomide. So that's the space that's being tested or will be tested soon, at least. And the drug appears promising in terms of efficacy and is tolerable and easy to administer and take. Thank you.
Thank you. I think we did omit the CAR T-cell presentation in the advanced setting. There is one that was presented that shows or demonstrates the ability to process and create these cells in a much shorter time than the current 35 days, which is definitely a challenge for patients with rapidly progressive disease. Next slide, please. Next slide. So I think we do very much need these new agents. You can see the list of provincially funded options, and there are some under review, also not on this list, such as selinexor and Bortezomib and Dex. I think another consideration is that as patients are starting to get quadruplets and CD38 drugs very early in their treatment, and now are already progressing first line on lenalidomide and soon to lenalidomide and daratumumab, a patient may be highly resistant to drugs after only a couple of lines of treatment. And I've already discussed that more advanced relapse remains a high priority need, as demonstrated by our own analysis. Next slide, please. So again, to end on a more optimistic note, this is a partial list of ongoing or upcoming Canadian trials for relapsed refractory myeloma. The industry trials in particular include a variety of bispecifics, either with daratumumab or pomalidomide or even lenalidomide. There's NK engagers rather than T-cell engagers. There's a lot of interest in Canada in particularly Mezi, which is more potent than Iber, and some novel agents as shown here. We do have a limited access right now to CAR T cells in the very advanced setting. Our center has CARsgen. There may be, there are intense work on made in Canada CAR T cells, but I think I'd invite the panelists to discuss, but until potentially cilta-cel is approved by Health Canada and funded, you can see the trend by industry has been to move CAR T cells way up front rather than have them available for multiply relapsed patients. So we are relying on these new agents. Next slide, please. So what are some of our future directions in our group? We really have on the books, we didn't go into detail, some bispecific studies under development, because these agents need to get out of just 3 or 4 centers and across the country to reach our important population from coast to coast. We have well on its way a Cevostomab, BITE, and Belamaf trial. There is an Renalidomide BITE trial with our own made in Canada CRS amelioration strategy. And we're having promising discussion with other companies for bispecific trials. One of the things we can do in CMRG is really work on toxicity mitigation, decreasing treatment burden. We are happy to deal with oral agents, fewer visits. There's a great deal of interest in giving the BITEs intermittently, not continuously, to reduce the significant risk of infection if you give these drugs on end until progression, which has been our practice pattern for the IMiDs in particular and many other drugs for a long time. We want to learn the best assessment tools. We didn't have time to discuss that there are several mass spec platforms with different characteristics and sensitivity. So we want to select the right one to put into our trials. Our database is expanding, but really our main priority, I think it's fair to say, for CMRG is to get drugs to our patients. And today, I'm happy to report that 476 Canadians have received new myeloma regimens that they could not otherwise access through our CMRG trials. And I think that's what drives the passion of everyone in our organization. So I will just say, if anyone wants to make a last comment on relapsed refractory disease, we are almost at our end, but if we have any comments from the group, and I'll also open it up to any questions before we close. No?
Any questions in the chat there, John?
No, nothing so far, but people could feel free to add them in the chat box if they choose.
Yes, and this is being recorded and will be available via YouTube. And I'd like to thank everyone for their participation and attendance on a Friday afternoon. And hopefully we will have our 4th CMRG ASH update next year. We wish all of you a safe and healthy holiday season in 2013. And again, thank you for your attendance. I'd like to thank the panelists, Lydia, for all the mechanics of this meeting. My role is not to touch anything on a media platform, and I wish all of you the best going forward. And thanks again to our panelists. Good evening.
Thank you. Bye-bye.
Thanks, Donna. Take care.
Thanks. Bye-bye.